The system is broken.
I think it's crazy.
I'm on the hook for this.
There's no way I can pay that.
It's crazy. If I ran my business the way they ran that, I wouldn't be in business. That's all there is to it.
No other American business does business quite like this.
They wouldn't tell me their prices.
You have no idea what you're being charged.
Confusion is not an illusion. It's as commonplace
What is this?
as the common cold.
There's no transparency whatsoever.
In a country where little more than a broken bone
I was livid.
can break the bank,
It was a total shell game.
9 Wants to Know decided to try to answer why by asking you, why not? Why not show us your bills? Show us the charges and the codes and the nonsense.
It's not right. It's not right.
Our year-long project amassed a database of hundreds of complaints. Within those, we found problems with everything from emergency room codes.
They billed you at a level 4. Do you know why?
No. No idea.
To charges for routine tests.
I don't know who they're expecting to pay that.
We've also discovered mistakes.
Within days after you got involved, the bill was dropped by $4,800 some dollars.
And helped erase from patients' bills more than $150,000.
Your involvement in this was the key factor in getting them to admit their mistake.
Patient after patient has lost patience with the rising cost of healthcare, where no one knows what anything costs until a bill shows up weeks, if not months later.
There's nights I don't sleep because I'm worried about having to sell my house now.
Tonight, we'll show you their bills to help you better understand yours, and we'll show you how to fight back.
So we just have to say, no, we're no longer going to play by the rules of that system.
As we seek accountability
This one right here, 104.
within an industry that's in the business of not telling you the cost of doing business.
Why can't you just tell me what the charge is?
You deserve answers.
We're trying to find somebody from SCL. Can you tell them that we're here?
Yeah, this is ridiculous.
Tonight, we'll give you more than a few, simply because you decided to show us your bills. This is not about Obamacare or Trump care. This is about your care, specifically the cost of your health care. Welcome to Show Us Your Bills.
An investigation made possible because of you. Your bills, you told us, of a broken, fragmented, and impossible to understand system.
A system that conceals costs.
And works a little something like this.
Think of this the next time you go looking for groceries. Look at all those aisles. Let's head to the bread aisle. In the free market of the supermarket, you know the price of everything because everything comes with a price tag. $2.79 for that. Cool. Now let's head to the not-so-super market of the American healthcare system. Here, they let you take that loaf home, no checkout, maybe a small copay, maybe not. Then, a month or so later, the bill arrives, and your provider wants $279 for that loaf of bread. Why? Can't say. Your insurance will pick up some, not all, but not as much as your neighbor who has a different insurance plan. Why? Who knows? Confused? You should be. That's the point, because here no one knows what anything costs, whether it be a loaf of bread or, let's say, a urine drug test. This is a story about urine. No, this is not urine, just apple juice. Real urine is gross. And as we said,
I panicked.
This is a story about urine. Sharon Hensley's actually, and why the testing of hers led to this 4-figure charge.
We could have gone to like Hawaii or something for that.
Or Paris. round trip for her and her 2 kids, 5 nights nice hotel.
Bonjour.
And even a few 5-star restaurants.
Oui, oui.
Not that she's going.
I suppose you could just pull out your wallet and plop out $6,200.
Well, they're gonna, good luck.
So now's the time we should tell you what a urine screen can cost. And in order to do that, let's introduce you to Richard Matucci and his pee cup.
That's exactly what it is.
He'll test your urine for all sorts of things.
You can do a pretty good test for less than $100.
Less than $100.
For that, it'll tell you if your urine tests positive for 20 drugs. Some legal, some not. Add a few more drugs and the cost goes up a little.
The high 200s most likely.
So what happened to Sharon?
I now have chronic pain in my chest.
Stick with us, because this will make more sense in a moment. Recently, Sharon went here to Dimensions Pain Management after numerous surgeries left her with nearly daily flares of chest pain, according to medical records she gave us.
When your heart hurts, your brain is not happy.
Dr. Leif Sorensen asked her for a urine screen. We'll show you this. Not hers, because, yeah, gross. Anyway, urine screens are now common in pain management. Blame the country's addiction to painkillers. Doctors order a test in order to tell if you're actually taking what you say you're taking.
You don't get a choice.
Mm-mm.
For a urine screen.
For urine screen, yep.
So remember Matucci's test. That test tells you if you test positive or negative for, let's say, 20 drugs. It's cheap and easy and involves one test and one charge. Let's call that the cheeseburger test.
Yum.
Why? It'll make more sense in a moment. There's another test that can also be done in order to know specifically how much of each drug is in a person's system. It's more complex. Instead of one test for 20 drugs, this involves testing the urine sample 20 times for 20 drugs. 20 tests, 20 charges. That can get pricey. So we'll call it the filet mignon of urine screens.
Delicious.
Others call it a profit grab.
And there's just no other way to explain the numbers when it comes to urine drug testing.
California attorney and urine drug testing expert Harry Nelson says 80% of the filet mignon tests are not medically necessary.
Basically, a lot of money is being spent to test for something where we already know the answer.
Which brings us back to Sharon. She initially did a cheeseburger test. It turned up negative for everything but this. And that was to be expected because she told the doctor beforehand she was taking the prescribed barbiturate. Still didn't stop the doctor from checking box after box after box for the additional and more expensive round of testing.
This one right here, 104.
Hey. Hi, my name's Sharon.
Golden-based Insight Labs then proceeded to do test after test after test.
Right now, this is telling her what she owes is $6,250.
As we explained to a camera-shy lab tech, Insight's tests offered little insight, other than to confirm that a 41-year-old mother of 2 with no history of drug abuse was not taking cocaine, meth, ketamine, fentanyl, ecstasy. You get the point.
You're supposed to direct all your questions to Justin.
Yeah, Justin's not calling me back.
Eventually, he did tell us this.
More than likely, we'll just be losing money on it.
If her insurance wouldn't pay the $6,000, she wouldn't know a thing.
Which might make you wonder, why should you care? Well, let's just say there are a lot of labs doing this, and sometimes someone does end up paying, like, let's say, the state of Colorado, and you, and me. When I tell you that Colorado is now spending 26 times more per month on urine screens than it did in 2014, what do you think?
I think that's a lot.
We found the state's Medicaid program in 2014 spent on average $52,000 a month to urine screen Coloradans. Last year, it spent $1.35 million a month, and the state didn't even know about it.
How do you not notice that?
Until we told the program's medical director, Dr. Judy Zerzan.
We had looked into this a couple of years ago when other states were having this problem, but hadn't refreshed that until you brought it to our attention.
Very concerning to me, Chris. First I've heard of it.
We told State Representative Joanne Janal the state didn't just pay more because of more patients. Our data found in 2014, Medicaid paid for 1.4 tests per month per patient. In 2016, it paid for nearly 8 tests per month per patient.
Do you think your colleagues would be interested in this data?
I think they would, yes.
She's asking for a review.
We're always looking for ways to do things better.
As for Insight, a spokesperson told us it operates in accordance with all laws and only performs tests under the orders of a prescribing physician. Centura Health, which owns the prescribing physician's practice, refused comment on the story.
Thank you.
Leaving us to wonder, if our story about urine really isn't a story about urine after all.
I don't think that these companies realize how much stress this puts on the patients.
Sharon's story is not an anomaly. We've received a dozen more stories from patients complaining the same thing, many whose samples went to Insight Labs.
$7 grand, if not more, for a pee test.
P-test.
The state's Medicaid office tells us our story will bring about change.
Currently, it's considering limiting the number of tests that can be billed per patient.
Surprise! That seemingly simple visit is going to cost you.
I just wanted an MRI, didn't want to buy the machine.
About dropped over. Almost had a heart attack. I couldn't believe it. I thought it was a misprint.
Misprint? Nope. Sometimes it's just a numbers game.
Do you know why this was a level 3?
I have no idea.
ERs do it. We'll tell you how. This guy says if this is indeed a game, it's time to stop playing by their rules.
That's it. Deny payment. No negotiation. No middle ground.
Surprised? Don't be.
How can anybody do this?
We're back in a few. A short few. No fooling. Meet Joe. Hi. Why do you need to know Joe? Because not long ago, Joe broke his toe.
Son of a...
Joe's going to help us explain medical bills.
Great.
Because staff at an ER did a lot of things to Joe and his swollen toe. An x-ray, a few tests, even gave him some meds for his pain.
About time.
Of course, once Joe left, the real work began. The doctor's notes headed to the hospital's coder, who then translated the words into numbers. Codes, really. This number for the x-ray, this for the meds. In the U.S., there's a current procedural terminology, or CPT code, for everything. Everything. As of last count, there were more than 10,000 CPT codes.
Wow.
And here's where this gets tricky.
Uh-oh.
Each hospital can, and often does, assign its own charge to each code. So one hospital's charge for an x-ray might be this, another's might be that. And few will tell you up front what that charge might be. Anywho,
get to the point.
In Joe's case, the hospital sent Joe's codes to Joe's insurance company. where based upon their negotiations, Joe's insurance agreed on a lower price. Stay with us because this is important.
Okay.
Problem is, every insurance company has its own negotiations and typically offers multiple plans. In Joe's home state, there were 944 approved plans in 2014 alone. Each one had different premiums, co-pays, deductibles. You get the point.
Yeah, it's complicated.
And so, what Joe's insurance did for Joe might not be what Mo's insurance will do for Mo.
Son of a...
Back to the bill. If at any point a code is wrong, it's typically the job of the patient to spot it, not the insurance company. Some estimates suggest 10% of all bills contain errors. Other reports say it's higher. Much, much higher.
What the...
Once the insurance company has outlined the codes and processed the claim, it'll send an explanation of benefits, or EOB, to the patient, telling him or her what to expect to be billed. In Joe's case, a few weeks later, he received the bill from the hospital.
I owe how much?
Which, as you might have guessed, was not so low. When he asked if he could forego paying for the work on his now healed toe, the hospital and his insurance replied with one simple answer.
No.
Pay up, or it's off to collections. This will undoubtedly go.
Joe is not alone in his woe. Our database includes more than 300 names and 300 complaints. We've interviewed a few dozen of them to help you avoid becoming the next person to have to show us your bill. Here's a sample.
Say hello to my MRI machine. MRI stands for magnetic resonance imaging. When on, they make a ghastly sound. But for the most part, they do good things.
I've had chronic ear infections in my left ear. It just never seems to clear up and never goes away.
His adventure started here. Mile High Odor, this place. There, a doctor said, I'd like to give you an MRI. So the doc sent him here to Lutheran Medical Center, where before they did this, Tony says he asked, how much?
They just were very evasive and wouldn't tell me.
But he figured if a doctor wanted one, he needed it. So into a machine like this, he went. A month later, the Carrolls received a bill for $5,721.89.
When I got the bill, I called them. I said, hey, I just wanted an MRI. I didn't want to buy the machine.
Turns out their insurance didn't like the fact they went to a hospital-based MRI and so agreed to only a modest adjustment, leaving the Carrolls with the rest.
I'm on the hook for this.
Healthcare Blue Book suggests the fair price for a brain MRI is close to $1,100. There are non-hospital-based imaging centers that'll charge you $650 for one, but hospitals tend to be a little more guarded with their prices.
They wouldn't tell me their prices.
We warned the hospitals we might do this if they didn't go on camera with us.
So we went to the corporate offices of SEL Health, owner of Lutheran Medical Center, just trying to get a better idea of why the Carrolls were asked to pay thousands.
Hey guys.
Are you filming right now?
We are. We're trying to find somebody from SEL.
There, a very nice security guard told me to take a seat. I did, and then waited for a nice woman to give me a phone.
Hi Brian, this is Chris Van Intervene from Channel 9.
On it, Brian Newsom, spokesperson for SEL Health. FCC regulations prohibit me from airing what he said, but he did tell me billing is, quote, a complex issue, hard to boil down into a soundbite. And SEL cannot provide you with an on-camera interview.
You would think that it would be fairly easy for a hospital that does this on a day-to-day basis to justify their billing practices.
As for the Carrolls,
who has $5,000 sitting around in their bank account just to pay you?
Once we started pestering Lutheran decided to knock off $4,000 from the bill.
That's why I contacted you guys, because it was like really frustrated.
Still left them with more than $900 to pay, all for the use of a machine and the privilege of hearing that ghastly noise. Rare diseases bring with them tests, all sorts of tests. For many, the tests often include blood tests and lots of visits to the doctor.
I have a condition that requires me to see a doctor every 3 months.
Erez Raviv first came to this building in 2014. In 2015, he grew used to paying close to $30 a visit for the labs, a price he didn't like, but endured nonetheless. And then last year,
I got a bill in the mail for clinical services.
Raviv received what he considered a mystery charge of $188.24. Look closely because there it is. $188 for an HB Level 2 OP visit. His responsibility, $163. Raviv openly wondered, what was it and why? Why the change, all things considered?
Same building, same people, same doctors, same nurses, same service.
Of course, one thing was different, mainly the signage on the outside. In April of last year, hospital giant UC Health scooped up Raviv's doctor's practice, which allowed UC Health to consider the building an outpatient facility, and so it charged accordingly. In Raviv's case, $188 for that OP or outpatient visit.
Really infuriating.
As outlined in this letter to patients, it's called hospital-based billing. UC Health says being affiliated with a hospital allows it to invest in the latest technologies and enhance our cancer care. But it also allows UC Health to charge a facility fee where no fee had previously existed. Raviv has since moved on to a privately run practice an hour away.
I don't have a choice.
He's mad, but UC Health tells us it's merely charging what the Centers for Medicare and Medicaid Services allows. That's true, and something to consider when your private doctor's office suddenly joins forces with a hospital. They might not hold doctorates in medicine, but auto mechanics get paid to diagnose nonetheless.
Each job requires certain parts.
Of course, when mechanics want too much, mechanics like Ryan Kolibaba know what can happen next.
If you feel like you're getting ripped off, you can always go down the street.
Right.
Not so when the person getting paid to diagnose works in an emergency room.
You can't say, no, stop. Take me over to another hospital. Let me get another doctor's opinion.
And thus the quandary Ryan Kolibaba now faces thanks to a bill he showed us via showusyourbills at 9news.com.
There's no transparency whatsoever.
We'll let his email tell some of the story. In May of last year, after he experienced a sharp shooting pain in his lower back, he went to University of Colorado Hospital. A blood and urine test determined kidney stones. Less than a year later,
the exact same pain, exact same spot.
He was back. Even told him probably kidney stones. This time, however, in addition to the urine and blood test, a doctor ordered a CT scan.
Did you have any idea what a CT might cost before
I had no idea whatsoever.
Before the results of the CT even came back.
They came back with the urine test and the blood test, and they say, oh yeah, you have kidney stones.
So no one was surprised when the CT revealed that as well. Of course, only Ryan was surprised to learn what the hospital would eventually charge for it.
It was just bam, 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 and then after the fact, when you get the bill, you then realize, hey, I should ask more questions.
Total charges for the visit, $13,213.77, most of which was for that CT scan. After insurance, $2,800 was his responsibility.
I think it's extremely unfair.
UC Health did tell us this about Ryan's case.
I will be the first to tell you that emergency departments are expensive. Emergency departments are the most expensive level of care.
Of course, if medicine worked more like car repair, Ryan might have known precisely just how expensive it could actually be.
You can't just decide to do whatever you want to do and then bill people after the fact.
We found imaging from CTs to X-rays to MRIs. The costs, they vary a great deal from one facility to the next.
Huge deal. Your bill showed us CT charges ranging from $2,000 to $10,000. Now for the good news. We've helped erase more than $150,000 from your bills to date. We're going to highlight a few of those cases during the rest of this show.
We thank you for putting the pressure on them. Within days after you got involved, the bill was dropped by $4,800 some dollars.
Okay, that's us. All right, and it's us. Okay, I see. Okay, so. Hi everyone, I'm Katie Wilcox. I'm an investigative producer here with 9 Wants to Know, and I want my panel to introduce themselves. Ben, we'll start with you.
Good evening, Ben Miller, Farley Health Policy Center.
Sarah Ochterlony, Consumer Protection Attorney.
Kevin McGarvey, Emergency Physician with Hippo Health.
Sharon Hensley, very experienced patient.
All right, and thanks to all of you and all of you for sending us some of your questions. So a lot of what we've seen so far in some of your comments throughout the rest of these stories is that there are patients who are paying a lot of money. This one says $750 a month with a $6,000 deductible. Her insurance isn't covering anything. How are we going to start addressing some of these high costs of health? Ben, do you want to?
Sure. Well, first of all, we have to have conversations like this one. We have to be made aware of some of the issues that are out there. Most people don't understand how ridiculously complex and expensive healthcare is until they're sick. And so you don't ask the questions like, what should I be aware of, until it's way too late.
Absolutely. Kevin, do you want to talk a little bit about that?
Totally agree with Ben. I think that we have a system that is very difficult to navigate, and often the patient gets stuck in the middle with a terrible bill. We've talked a lot today before about transparency being a major issue, and that patients should have the rights to see at some level what's happening with their charges and the costs around the state. So.
Sharon, you were, for any of you guys who've been watching this whole time, Sharon was in one of these earlier packages. Tell us a little bit about your experience.
I'm a heart patient, and so I get a lot of bills, I get a lot of tests, I have a lot of hospital visits. So I have a good idea about what hospitals charge, what doctors charge, what tests should cost, what blood tests should cost, what urine screenings cost. Even urine screenings done in the ER. Every time I go in with cardiac symptoms, they run a drug test. And so I knew that when I got this bill for $6,250 that something was definitely not right.
Thank you so much for all of you guys. Okay, we're doing this during the commercial break, so make sure you're sending us your questions. We're on Facebook Live right now. Obviously, you guys are watching us there.
Your bills showed us the enormous cost just to walk into the emergency room.
It's called the facility fee. For many, it was the most expensive charge on a bill. We found charges ranging from $700 to as much as $12,000.
If the walls of an emergency room could talk, they wouldn't always tell a tale of terror and chaos. Some stories might even seem mundane.
52 minutes from start to finish.
Ordinary.
Yeah, it was maybe a 20-minute visit.
Unremarkable.
Less than an hour in and out.
Laura Prinzi went to Swedish Hospital's Southwest ER due to a knee problem.
It was like every couple steps I would have shooting pain.
Total time with the doc. Let's just say I'll spend more time on this story.
3 minutes.
Yeah, literally 3 with him.
Doctor told her, you're good. No tear.
So no x-ray.
No x-ray.
No MRI.
Nothing.
Weeks later, she received this.
It was $2,700 and some change. That's a lot of money. Yeah.
The only clue as to why this, EMER DEPT Level 3.
Do you even know what an ER Level 3 means?
No. Mm-mm.
Do you know why yours is a 3?
No, they can't tell me.
They can't. We'll try. There are 5 levels of codes for ER visits, 1, 2, 3, 4, and 5. 1s and 2s likely result in facility fee charges in the hundreds. 3s, 4s, and 5s result in charges in the thousands. Now you'd think a 3-minute visit would be a 1, but it's not.
A 1 is somebody who is essentially seen at triage and determined to have no emergency condition and is sent away.
ER Dr. Dave Friedenson knows that's why almost no one gets a 1, because 1s require no work and almost no one goes to a hospital for nothing. Once the hospital does any work, the real coding begins.
Is it as simple as saying the more they do, the higher the code?
Yes, so the more the hospital does, the higher the code.
And one little thing can bump a 2 to a 3 or a 3 to a 4.
If a doctor decides to order a splint, even if it's a cheap splint for somebody, it can up the code?
Yeah, absolutely.
And that's almost certainly why Prinzi's 2 became a 3.
They gave me a soft splint, and I was on my way.
This, to me, is just outrageous.
Heidi Westbrook's stepdaughter's bout with a sore throat led to a level 3 charge at a UC Health ER in Parker.
She was concerned she had strep. 1
pulse ox and 1 negative throat culture later, this.
Right now, I'm being asked to pay $2,495.
For a half-hour visit?
Yeah.
What do you think of that?
I think I'm in the wrong industry.
I thought this was a good one for you to hear about.
Keith Westfall wrote us not simply because his daughter's alarming rash led to a level 5 facility charge at Castle Rock Adventist and a $9,800 charge.
That's a lot of money.
That's a lot of money.
He also wrote us because the next day, with the same rash still there, he and she went back.
Same kind of deal.
Same deal. Same deal.
But in this case, it was a level 3.
Yeah.
Why?
Good question.
It all seems a little arbitrary, right? Not so, say the hospitals, who all told us they follow coding guidelines put forth by the American College of Emergency Physicians, or ACEP. Which brings us to the story of Paige Tholey.
It was miserable.
And her quick visit to St. Anthony's ER for a bad bladder infection.
They just tested your urine.
That's it. A peed in cup.
The doc did also give her an over-the-counter medication. And for that,
they billed you at a level 4 admittance. Do you know why?
No. No idea.
Here's why, at least according to Centura, the hospital's owner. It assigned points to everything the hospital did. Urine test, 2 points. Over-the-counter medications, 1 point. Discharge instructions, 2 points. 5 points in all, which according to the letter Centura mailed Tholey, is a level 4 visit and worthy of a $3,400 charge, half of which remains her responsibility.
I was shocked, and then I was mad.
When we challenged the code, Centura provided a link to the ACEP guidelines. Remember those? After clicking their link, we wondered if Centura had even bothered to do the same, because ACEP's own page featured the case of a woman with a bladder infection who received a urine test, over-the-counter medication, and discharge instructions. And guess what?
Ridiculous.
What Centura calls a level 4 for Tholey, ACEP calls a level 3. Other Centura bills we've seen suggest the difference between a 3 and 4 can be as much as $1,000.
I'm not sure how that alone becomes a level 4.
Dave Friedenson also knows there's really no recourse here because ACEP guidelines are nothing more than suggestions, requests to be reasonable.
I want to backtrack for a second. They're telling the hospitals to be reasonable.
Correct.
And they're asking the hospitals to set up their own standards.
Correct.
So there's no national standard for how they code.
That's correct.
And with no standard, Colorado hospitals are coding more level 5s than ever. In 2009, they made up 23% of all visits. Last year, 34%, according to data we received from the state's all-payer claims database.
They're gonna love us.
After repeated requests for comment, we visited Centura's headquarters looking to know more about Tholey's score.
How you doing?
Centura kicked us out.
Unfortunately, we have to ask you to leave.
In an email, a spokesperson insisted Tholey's case does support a level 4 charge, but didn't elaborate when we asked about ACEP's suggestion. As for Tholey,
I will definitely think twice ever before going into an emergency room again, which is a shame.
Her 5-minute consult now has her on a payment plan.
It's what I can barely afford. It's like $400 a month.
All for the kind of visit the walls of an emergency room might find too boring to even talk about.
There was nothing more that I could do. Nothing happened until the story aired, and then all of a sudden, it was resolved.
All right, we want to start out with Dr. Kevin McGarvey here, who is actually an emergency physician yourself, yeah?
Yes.
What's sort of your reaction to some of the information we just heard?
You know, it's a tough situation in healthcare today. There are so many parties that are spending incredible resources and mandated to provide care by specific rules, mandated by federal and state guidelines. With emergency costs, ideally you would go to the emergency department when you're having a medical emergency, but sometimes you don't know if it's an emergency or not.
Right.
And neither does the physician, which is why we have the ability to then assess someone over time. And with all the resources that go into the ability to see and treat any medical emergency, any time of day, anyone that comes in, there are incredible expenses associated with that.
Real quickly, in about a minute, what do you think is the most important thing for people to think about before they go to the emergency room? We get so many comments about, well, strep throat's not an emergency, or this or that. Right. What is the most important thing for a patient to think about before they go to an emergency room?
I think the most important thing is to think about first, if you do have a doctor, can you get access to that doctor and be able to talk with them? Is this an emergency or not? And if they feel it is, or you're not able to get access, and you feel it's an emergency, you probably should get evaluated.
Absolutely. Thank you so much. And thanks to everyone who has their questions keep coming in. Sharon, I know you had a pretty good response to that story. That's something you've experienced?
Emergency rooms?
Yeah.
Yeah.
A lot of times.
Yeah.
Okay. Well, we'll have to talk more about that in our next commercial break. And yeah, so what do you think was like the most important thing that you learned in that last segment?
No.
What do you think is most important about the billing? I mean, you were talking a little bit about testing.
About testing.
Yeah.
Yeah, just to question the testing. I feel like with me, I'm at high risk for heart attack and stroke, and so I feel that when I go in, that there's a possibility that, I don't know every time, but I think that it's going to be questioned less, because there's always a possibility that I'm having.
Yeah. So thanks, you all. Keep the questions coming.
There's nothing quite like the feeling of opening up a bill and seeing there at the bottom, you owe $33,000.
And it's like, how am I expected to pay that? I'm not working.
Don Benetti,
I have no income coming in,
is fully insured. But a recent visit to Parker Adventist left him wondering what fully insured really means.
They found that there was a clot at my aortic valve.
Basically, he was about to die. Weeks later, he opened the bill, and the shock almost killed him. His insurance picked up nothing. No adjustments, no payments, nothing.
They just said because I was out of network.
Yes, he'd been to Parker Adventist before, but that was before he changed insurance companies. This time, he went for an emergency, and his insurance wasn't in network with the hospital, and thus the problem.
I mean, there's nights I don't sleep because I'm worried about having to sell my house now.
And so before contacting us, he offered what he could.
I did make a $25 payment just so it wouldn't go to collections or mess up my credit.
The Kaiser Family Foundation said recently 1 in 5 insured Americans reports problems paying medical bills. Benetti says Cigna told him he needed to transfer out of Parker Adventist once he was stabilized to an in-network facility, and that's why the claim was denied. Of course, at the time, Don was recovering from nearly dying.
So I didn't know that that was an option for me.
After contacting us, we contacted both Cigna and Parker Adventist. Days later, Cigna wrote us and said, unfortunately, we fell short in this instance, and then told Don he no longer needed to worry about that $33,000 bill.
As you heard, Don Benetti told us that when he got that bill, he right away sent in $25 just to make sure the hospital knew he was trying to make payments.
But some billing experts say, don't even do that. Demand answers first, and if the hospitals won't give them to you, maybe consider this.
ER levels $900. One CBC $370.
Understanding the world of medical billing requires an expertise in neither medicine nor accounting.
Current balance due?
To discover far too often
This defies common sense.
the numbers
It's frustrating.
do not add up.
I think it's outrageous.
Think of it like A plus B equals Y.
There's something definitely wrong.
As in, why do you want me to pay that?
There's no way I can write a check for $20,000.
Andrea gets mad just thinking about the one-day hospital stay for her son.
And I'm still waiting to find out how much of that bill I owe.
Show Us Your Bills at 9news.com showed us your level of anger and frustration. We asked, people like Denton Anderson answered.
I got a mosquito bite and it swelled up.
Swelled up big.
The swelling went from here up to about my elbow.
Big enough for him to go here.
The doctor came in, he looked at, oh, yeah, it's allergic reaction to mosquito bite. Take some Benadryl.
And some prednisone, an anti-inflammatory.
You were there less than 5 minutes.
Less than 5 minutes.
Total charges, $2,160, more than half of which was his responsibility.
No x-ray.
Right.
No MRI.
Right.
No CT.
No stitching, nothing. Just looked at it and said, hey, you'll be okay.
I had a bicycle
accident.
Before Zdenek Novak's ACL surgery, he made sure everyone, from the surgeon to the anesthesiologist, was in network with his insurance. And yet,
I'm getting bills that I didn't expect.
turns out the brace he wore for one day post-surgery came from an out-of-network company.
Nobody actually warned me about the cost if it's not covered.
His bill, $695 for a brace he found online for $194.
Same brace. It even has the same insurance code on it.
3 people, 1 question. Why? 3 people all caught in a cyclone of complexity, a round and round game of the seemingly absurd.
So we just have to say, no, we're no longer going to play by the rules of that system.
Hi, I'm David Silverstein. And
David Silverstein founded BrokenHealthcare.org to try to prove a point.
I'm saying enough is enough. We're not going to compromise. We're not going to take no for an answer.
He says if providers can't provide specifics as to why they billed the way they did, then patients shouldn't pay. Not a dollar, not a dime.
That's it. Deny payment. No negotiation, no middle ground. Either we're going to get answers to our questions or the bill's not going to get paid.
He challenges everything from emergency room billing codes to bills for nondescript procedures like this one, for toes.
And it just says toes. One line item, toes. The point that people would pay a bill that simply says toes is beyond me.
Andrea Getz's $20,000 bill included a $2,730 line for labs. What labs? Who knows? Denton Anderson's bill included a $30 charge for 3 prednisone tablets, $10 a pop. We found 20 online for $5. That's a quarter for 1.
Yeah, I feel like I overpaid a little bit.
I want full transparency into pricing.
Silverstein ultimately wants providers to justify every single charge, no matter how small.
You have to realize that there's repercussions.
Consumer protection attorney Sarah Ochterlony says before you go rushing onto the no-pay bandwagon, you must consider unpaid bills, even medical bills, can go on credit reports.
1 in 5 credit reports have some form of medical debt on them.
She does say Silverstein is still on something when it comes to patients questioning their bills, as billing errors are not unusual.
I think at that issue you have to be assertive and you have to press and ask for more and more detail to make sure that you actually receive the services that they said they're charging you for.
As for Silverstein, he says he actually wants to get sued for doing this. Yes, he wants to get sued, if only because he says a lawsuit will grant him more access to what hospitals are charging.
Pardon my French here, but you kind of like the idea of being a pain in the ass.
I don't think we have any choice.
So far, he hasn't met a bill yet he's had to pay. And in a world where dollars and cents
$213 for pharmacy, they gave him antibiotics.
seem to defy common sense.
Yeah, it was shocking. Kind of took my breath away.
He figures when things don't add up.
It's like you're buying something, but nobody tells you the price.
When that happens,
Moderate $300.
it's time to finally start asking, why not?
The fact that we have to wonder what the prices are and that we have to be surprised after the fact is crazy.
Okay, but before you really decide just not to pay a bill, there can be some serious consequences, not the least of which is getting that bill sent to collection. We'll talk about that in greater detail with our panel tonight. They're on 9 News Facebook Live right now. There they are, and we're going to all be answering your questions until 8:30 p.m.
I just wish that it didn't have to get to that point. I feel like a big weight's been lifted off my shoulders.
I want to start with you. Can you just talk to us a little bit, Sarah, about what could happen if someone refuses to pay their bills?
Right, so by refusing to pay your bills, you open yourself up to going into collections. Hospitals themselves, especially the larger systems, have their own in-house collectors. But some of the smaller hospitals can send you to a collection agency, in which case you'll be hearing from somebody who you may never have met before in the hospital and be trying to explain to them some of your medical bills problems.
At least one of you have talked to us about having wages garnished. What is that? What is getting wages garnished?
Wages garnished is an extreme process.
Okay.
It doesn't happen very often, but it can happen after a lawsuit has been filed in the debt collection process, and the court is part of that process as well.
So what is the most likely thing to happen when you get a bill that you just simply cannot afford?
So it depends on where you are in that phase. If you're still within the hospital system, your best recourse is to talk to the hospital itself and explain to them that you can't pay. A lot of hospitals, especially the nonprofits, have financial assistance programs as well. And that's the point where you need to go look at the hospital's information. And it's very important at this point, any point when you're disputing medical bills, to read closely and follow the instructions on the documents. Just telling somebody over the phone that you're having a problem isn't going to do the trick.
Okay, so you have to kind of, that's a lot of work for some people, I know.
That's a lot of work, especially if you've had a serious injury and you're not feeling well, to go through and read that fine print, send the letters, take copies of your statements, those sort of things. That can be a real burden, but it is very important to protect your legal rights.
Kevin, do you have anything to add from kind of your perspective, like from the emergency room's point of view?
From the physician's point of view, it's sometimes hard to be a part of that process because it is separate.
Thanks so much. Thanks, you guys.
Cheap is not a word typically associated with healthcare. It is a $3.2 trillion per year industry. And that means lots and lots of bills, some really, really big.
Excuse me, I'll be irritated.
Bob Costello's bill was not big.
A minor bill, but...
But when Swedish hospitals sent him to collections for an unpaid bill of $16.36, he said, seriously?
My inner cheapskate says, what is this? And it's 20 bucks, that's take my kid out to a nice meal.
Nice meal, maybe not. Still, he complained nonetheless.
I said, whoa, I didn't get any drugs. What are these drugs?
2 drugs he never got.
Famotidine something, injection. I definitely didn't get that.
The hospital eventually sent him this letter telling him, you know what? You're right. Turns out mistakes like this happen a lot. Pat Palmer is the founder of the Medical Billing Advocates of America. She told me 80% of the bills she sees contain at least one error.
And I'm being conservative.
Her advice, ask for an itemized bill every time. That way you can at least tell if they're billing you for something they didn't do.
Irritation. A little irritated, that's it.
Because who knows, the next mistake might not involve a mere $16.36.
I've always been looking at my bills because I only have so much money. I hate to give it away for free.
Since we started our series on medical bills, we've received hundreds and hundreds of comments, questions, and concerns. Here are some of your thoughts. Cheryl Jacobs says, I think it's all about greed.
Heard that one a lot. LaKendra Jacobs says the healthcare industry on a whole is an unfunny joke.
Yeah. And Christopher Shepard says this is where the reform needs to actually be.
Let's hope this is the start of a conversation.
Your involvement in this was the key factor in getting them to admit their mistake.
All right, and Ben, I want to start with you. We just got one that came in on Facebook that just is seriously, why are medical costs so inflated? Why are they more in the hospital than you could get at the grocery store, for example?
Well, healthcare costs are inflated in general because they can be. I mean, the market will allow any price to actually exist that it will bear. So, I mean, essentially, you can have prices continue to rise and rise and rise, and it will continue to rise until somewhere, somehow, someone says no more. But right now in healthcare, with 18% of our GDP in healthcare, I mean, we've got a major problem that needs to be addressed, and currently we're not stopping those prices.
We also got one comment that said, look, and actually one person we interviewed had gone to collections for less than $20 on their bill left over. It's wild, it's wild. We've seen this happen before. I know that it is rare, but what do you think is really important about just taking control of these bills before it gets to that point? Any of you?
I mean, when it goes into collections, it's very important to meet the deadlines. You get a lot of legal protections under the Fair Debt Collection Practices Act, and in order to take advantage of those, you need to respond in writing very soon after you receive the first collections call and the letter that follows up. And that usually means within 30 days.
Ben, you just said how big of a deal this is. How many people are affected? How many people are affected by medical debt?
A lot of folks, and actually individuals that indicate that they have medical debt, most of them actually have health insurance. And so your initial thought is, wow, these are people that don't have health insurance, but it's actually most folks that do have health insurance. I want to point out one thing. The healthcare system should be in service to the person, not the person in service to the healthcare system. So we actually need to reverse this trend a little bit and give us the power.
Absolutely. So we're taking we're taking your questions during these commercial breaks. Keep them coming. We'll have 30 minutes with our panel, so we'll get to go a little bit more in depth immediately following this program. I hope you guys continue to watch them and continue to just keep letting us know what you think and feel. And remember, these panelists, we have an emergency physician here, we've got a consumer protection attorney, we've got a health policy expert, and of course Sharon, who has been in the same boat as so many of you. So please just keep these questions coming, and thank you all so much. Again, so we're on 9 News right now, and we will be live at 8.
They just were very evasive and wouldn't tell me.
How are our bills this high? I think it's insane what they charge.
Finding frustration and discovering discontent prove far too easy in a system designed to confuse.
And I'm not a millionaire. I can't afford this.
Nicole Krebs showed us her bills. So did Melissa and Marty Meltzer.
You get re-victimized over and over and over.
Just a few within a pile of hundreds.
It kind of feels like highway robbery, to be honest.
Heidi Westbrook had questions, so did we. Of course, answers didn't come easily. We asked for on-camera interviews and repeatedly received this short response: no.
Seems no hospital wants to talk to us.
We even invited those doing the billing to come by our station, read the complaints, see what we're seeing. We gave a date and a location and a conference room with water and snacks and macaroons, for goodness sakes. Macaroons! And guess what? We waited. And concluded maybe we just go to them.
So we warned the hospitals we might do this if they didn't go on camera with us, and now we're going to do it.
SCL Health billed the Carrolls more than $5,700 for a CAT scan that would have run them less than $1,000 at an imaging center.
They're not willing to negotiate anything.
Hey guys.
Are you filming right now?
We are. We're trying to find somebody from SCL.
We waited for a while. A woman handed us a phone.
Hi, Brian. This is Chris Van interviewing for Channel 9.
Guy on the other end told me he'd consider an on-camera interview, and then never did.
What do you want to ask him today?
Just why this wasn't taken care of.
Centura wanted tens of thousands of dollars from Don Benetti.
We actually can't have you guys filming in here.
Money his insurance company eventually concluded never should have turned up on his bill.
He's just trying to figure out why there's a $33,000 bill that he's responsible for.
Unfortunately, we have to ask you to leave due to patient confidentiality. We can't have you in.
Are there patients in here?
There are. So we're going to have to ask you to leave.
Where are the
can't,
patients?
Unfortunately.
He'd like an answer at some point.
Yeah, this is ridiculous.
Same story over at Health One. We went there with Laura Prinzi.
So we only accept people by appointments, so you're not going to be able to speak.
Can you tell them that we're here?
But they're not going to be able to see you.
Are you sure?
Possibly.
How do you know?
Because I was already previously told that they're not seeing anybody today.
She just wanted to know more about her $2,700 ER charge for an ankle issue.
I think that's frustrating, that you can't even get somebody to talk to you.
Only UC Health Stan Weaver
I'm happy to talk with you.
was brave enough to tell us this on camera.
I don't think there's a single hospital or medical provider across the nation who wouldn't love to see a more simple and easy to understand system.
He even volunteered to take Julie Nelson's bill. Yes, That bill out of collections, a good thing considering the hospital kept sending it to the wrong address.
This can really break people.
You know, that was an unfortunate mistake, and there was a incorrect address for her. We pulled her account out of collections.
But here's the thing, and part of the problem for any patient. What happens when you want to know costs beforehand? Like, for example, the charge for a level 1 visit to a UC Health ER.
Why can't you just tell me what the charge is?
You tend to get a lot of this.
So absolutely, there's a lot of confusion out there.
These are predetermined negotiated rates. Why can't you tell me what I'm eventually going to be billed?
So we might not know what insurance plan you're on.
I have my insurance card right here. If I give you this, can you tell me what a 99281 is going to be?
So there are a few problems. First, insurance cards aren't always up to date.
This one is, I can assure you.
We also don't know how much of your deductible you have met.
I told him at that point I hadn't spent a dime.
You still can't tell me what a 99281 ER level charge would be?
And that's why you have to go back to your insurance company and talk to them, because they have worked out those negotiated rates.
But they've worked them out with you.
And that's the problem. In the grocery store of healthcare, not even a loaf of bread carries a price tag.
Hospitals and insurance companies are not always going to make it easy on the patient, are they?
They never make it easy on the patient.
Aspen Medical Billing's Victoria Karras challenges bills for a living. She says you need to know your insurance basics.
What are their deductibles? What is their co-insurance? What is their copay? What are their out-of-pocket caps?
Here's why. Your bills have shown us something as simple as a urine drug test can run anywhere between $100 and $7,000. Thank you, Sharon Hensley.
I saw that number and I thought, wow.
Imaging, things like CTs and MRIs, can cost 10 times more inside a hospital's ER. Thanks for the heads up, Tony Carroll.
When I got this bill, it was just outrageous.
Keith Westfall's bill showed us how ER facility charges can stretch well into the thousands. Era's Revives showed us why outpatient fees are the inevitable result of hospitals scooping up once private practices. Heidi Westbrook's bill showed us physicians' fees in ERs aren't cheap either. And Bob Costello showed us why asking for an itemized bill just makes sense.
They said, oh yeah, that's a mistake, we'll take it off.
This is why what happens next is up to you.
It's not so easy to be brave about it. But the braver you are, and the more you ask the questions, and the tougher you are, the better outcome you're going to have.
You showed us your bills. Your bill showed us no one needs to face this problem alone.
I'm so appreciative of what you guys did.
Mm-hmm. That's a lot of cash. So what can you do? How can you avoid a $7,000 bill, for example, for a urine drug test?
What do you do if you see a $20,000 bill for an out-of-network hospital stay?
Something you absolutely don't want to see. First, know your insurance. What's your deductible, out-of-pocket max? What's your copay? Find out ahead of time which doctors are in network.
You need to do some research. Next, know where you can go to seek medical attention if it's not an emergency. Do you have a call-in nurse or a doctor? There's also maybe an affordable urgent care clinic near you.
Know where those urgent care clinics are. Tonight, we've heard about high-priced urine labs and MRIs. If there's a procedure or test you can plan out, shop around, and find a place that won't charge thousands for what could cost just hundreds.
Yeah, once you get a bill, ask for details. Ask for an itemized statement. Don't be afraid to ask questions.
And remember, we still got it open. Show us your bills at 9news.com.
Yeah, thanks to everyone.
Yep. tell us when we're hot on Facebook. This is a much more casual discussion than the one that we just had over the last hour on 9 News. For the next half an hour, we're going to be on Facebook, and we have brought in people that are much smarter than me to talk about healthcare, what's wrong with it. They're going to be taking your questions by all means. This little side part of the screen, want you to put in those questions in Facebook. Join. I got a lot of people that are joining me right now. A lot of these people are smart, and they've got titles. Ben Miller, Eugene S. Farley Health Policy Center. Sarah Octoloni.
Nope,
Not
that's
Sarah
Sarah.
Octoloni, sorry. Sarah Octoloni, attorney. Sharon Hensley, you were featured in our story because you got the $6,200 charge for a urine screen. You should be very proud of that. And Dr. Kevin McCarvey, you are with ACEP here in the state of Colorado. I didn't totally hose that up. Thanks so much for joining us. Let's talk first. And this is a free-for-all, guys. So feel free to interject whenever you want. And this is Katie Wilcox.
Hi, I'm Katie.
Producer here at 9 News that has helped immensely with this entire project. We have just outlined for the last hour this horrific system that really does not benefit patients when they get the bill so late. Anybody want to raise their hand in class and sort of say, I got a feeling what might be able to help fix this problem?
I'll raise my hand.
Go ahead.
You know, I don't pretend to have a magic bullet for the complex issues as been outlined earlier with our current healthcare system. I think one issue that you brought up on the show that I think is worth a continued conversation is pricing transparency. It is incredibly hard to figure out what's being billed, what's being collected, what's being charged, and the insurance companies negotiating certain rates, the hospitals and the providers doing the same, and then the patient being stuck in the middle. I think there is a statewide database that we were talking about earlier, and I think there is data there that could help guide patients on what
So you
could
could
be
have
expected.
a rough idea of what things cost.
Something. Yeah.
Sharon, you were a patient who's been caught. Not only you don't have to go into your entire health history, but you have you interact with the system a lot. How much of a nightmare is this system to deal with when you continually sort of fear this getting a bill in the mail?
Oh, it's a part-time job. I mean,
And you're not joking at all.
Job. No, I'm not. It's I have a stack. In the last 4 years, I've accumulated a stack of bills like this. That isn't my total bills. That is the number of individual pieces of paper that I have had to take action on, either a phone call, an email, photocopies, calling labs, calling doctors, calling hospitals, calling insurance to figure this out and to sort through the mistakes, to sort through the redundant charges, to sort through the referrals, out of network costs. And it is a nightmare. It is a part-time job. You have to stay on it, and it's really unfair to the patient.
How often do you feel like you're on your own?
All the time. All the time. So
This speaks to the power of differential in healthcare. So one of my favorite books of all time, The Social Transformation of American Medicine, starts off by the dream of reason did not take power into account. The United States healthcare system has made it where you have no power. That the power comes from a lot of folks that are making a lot of money, and actually it should be in service to you. You should have the power and get to direct and decide, but unfortunately we don't. That's cruel.
It's almost like she's an afterthought in the healthcare system.
Yeah, I think someone on this stage has said that before. Yeah, you're right.
Right? It's just
Although I would like to make a point that as a patient, I've sat in a lot of doctors' offices through this whole process since the series started, specifically when Chris did the 10 patient stories. I went to a routine doctor's appointment the next day, which turned into, 3 specialist appointments, a visit to radiation records, and a blood lab. That's my life. So, but everywhere I went, there was a line of patients asking for itemized bills. And that was putting so much pressure on the doctors, on the staffs. They were stressed. Chris, they were stressed.
But this is a movement.
It is a movement. However, they need to keep it up because I went last week and y'all weren't doing this. So
ask for itemized bill.
Ask for the itemized
Sarah, what do you, I mean, people can get caught up financially in horrible circumstances.
Yes.
What's your advice here when people are sort of facing that $13,000 bill or $10,000 or $5,000 bill?
Yeah, so I think the first thing to remember is you're not alone. 14 million Americans have a medical debt on their credit report, which I think you equated having a medical problem to the common cold. Those 14 million people, that's the number of people that get the flu. So that's very, very common to have some sort of medical collection account on your credit report. And just remember you're not alone, that you shouldn't let embarrassment, especially if this is the first time you've ever had a debt in your life, don't let embarrassment keep you from standing up for yourself and asking questions and making those calls and writing those letters.
Caitlin says, wait, I thought they couldn't put medical bills on your credit anymore. What's going on here? Is that a surprise?
That's not quite right. There are some of the smaller medical bills that some of the credit reporting agencies, but not all, have voluntarily decided not to report. Also, the FICO 9 score, which is Fair Isaacs Corporation, is the biggest seller of consumer credit scores. Their new score has a way of factoring out medical collections debt and giving it less weight in the scoring. So the financials are figuring this out.
But keep in mind, we featured an individual, we asked you, and you were featured in that story where a guy's telling people essentially, David Silverstein, is essentially telling people, don't pay your bills until you get better answers. There is risk there. I mean, that is not without risk, is it not?
That is absolutely a risk. You know, the first risk is you're going to get collections calls, and then you have to be aware of your rights. The second risk is that you could get taken to court and have to defend yourself in court. If you don't show up, there's a default judgment against you, which is where things like garnishing wages starts to happen. So you can't just ignore it and hope it'll go away. You need to stand up for yourself.
Katie, feel free to interject
Absolutely.
whenever you want.
I mean, one of the things that keeps coming up, and I've seen it from a couple of different of our viewers, is just, I'm too afraid to go to the doctor because I can't afford it. Yeah. I'm gonna not get care because I can't afford it.
Doctor, that's got to worry you as a physician to know that there are people that are avoiding care because of
it's causing worse outcomes. And there's a reason that the United States ranks 20th in developed countries for a lot of health outcomes, but we are twice as expensive as any other country. There's actually something our team has been trying to work on to solve for that one issue. So we launch a new telemedicine service next Tuesday where you can download our app and get unlimited access to a Colorado emergency physician 16 hours a day for any given medical issue that you have questions on. We're not 911, but we think that there are a lot of issues that end up in the emergency department right now that could have been treated in other settings, whether it's in urgent care, in a clinic, or what we're doing with telemedicine.
Isn't the key to just find the right avenue to go down in terms of what we need for healthcare, and not sort of saying, well, this is, we're constantly going to ERs for things that we don't necessarily need ERs for, and maybe it's not the best fix.
So the national debate right now around healthcare is all about insurance. And so we need to have coverage. We need people to have health insurance, no doubt. That's an important piece. There's not a lot of discussion right now on how we're going to change the delivery system or the payment mechanisms that really incentivize bad behavior on the part of some people in the system.
Incentivize bad behavior. There's a lot of that. We see that within the system, is that it can make people a lot of money. Even good people, all of a sudden there's a lot of money flooding around this entire system.
It's a reimbursement model that has been built over decades.
Mm-hmm.
It's not really been innovated on in a long time. There are managed care models, there are value-based models, but at the end of the day, it's an incredibly complex payment system, and that often creates really terrible scenarios for patients where they don't have a good experience. So to Ben's point, I think there will be future channels. With our service in particular, we're going to offer it up for free for a month where anyone can try it out just to see what it's like, because it's kind of a new modality. And our goal is to just kind of have that direct care relationship again between the patient and the provider.
I bet a lot of doctors want to get back to that, right? I mean,
that's why most doctors go into medicine, is they want to help people. And it's a tough system for the providers and the patients, and the docs that I know are good, committed, hardworking physicians. So it's a tough system right now, and there are a lot of powerful interests that are wanting to keep things as is. So I think having a conversation about what is happening in healthcare is probably the most important thing.
Tell me what you think about this. I like to say this a lot in the newsroom. The status quo is making too many people too much money. At the end of the day, until we fight the status quo, I mean, it's not making Sharon Hensley money, but it's making other people money. And at the end of the day, that status quo is, we're so entrenched in that status quo that changing that is really what we're battling here, and that's going to be really, really difficult.
You said this in your newscast earlier, but there's a word, I think maybe it came from your segment, greed. Greed drives so much bad behavior right now in healthcare, and the reason that it continues to be allowed is because there's no parameters, there's no one stopping it. When you describe lack of standards, people will continue to bill for whatever they can bill because there are no standards on billing. And you're going to get as much as you can because that's the way that we've created healthcare in America.
Nobody knows what anything costs, right?
We're saying, okay, so one of the questions coming in from Thomas says, if Medicare is involved, can this fraud be grounds for criminal prosecution? Is this fraud? Are we talking about fraud? You guys all kind of shake your heads.
With Medicare, and I'm not a billing expert, but with Medicare, the rates tend to be fairly fixed. I think a lot of the bills that you're seeing, these surprise bills, you know, an $8,000 bill for a urinalysis tox screen, a lot of that's coming from the commercial payers negotiating with the providers, and there's not common ground, and then the result is a terrible bill.
I'd love for the lawyer to chime in here, but I have to say, like, Medicare does a pretty thorough job in auditing, and if you look at some of the news reports that have come out the last couple of years, they're cracking down on folks that are being fraudulent with Medicare. So it's not just...
I think Medicare is pretty good. I mean, I worry a little bit more about Medicaid, state programs that are still spending lots and lots of cash. And what are your thoughts?
Yeah, so I think that Medicare and Medicaid are both state or government sponsored, and so you have a lot of resources, either the state attorneys generals or even the federal government, who are out there looking out for the payor, which is the government. When you have private patients, so either the uninsured or people who have very expensive insurance with not a lot of coverage, those are the people who really don't have the professional government advocates looking out for them. So that's a problem. I work a lot in the financial services industry, and we have unfair and deceptive practices, and we're always looking for banks or other institutions, you know, taking advantage of consumers who don't know any better. And it seems like in the medical area, it's even more ripe for bad actors, because when people are injured or hurt, or they're seeing their family or friends in pain, you're going to say yes to anything. And that's exactly the kind of situation where you see people being taken advantage of legally.
And there's no standard of cost, right? And there's no sheet that tells me that because look, we deal with people that they get a bill for 10, 20 times more than what I see other people getting charged, and there's no standard of cost, and that really makes the system troubling.
And we've seen, I mean, in this database that we have, we've seen CT scans cost between $2,000 and $10,000. It's unclear why any one CT scan would cost that much difference, and I know that different hospitals can charge different prices, even if they're owned by the same ownership in some situations. So your database, I mean, that we've been able to build has helped give some transparency, but even if you know what the hospital is charging, you don't know what you're gonna have to pay. And so we're getting a question in right now from Cheryl. I mean, she just says, can anyone help me? And I think that that's a real question here, because even as we've been investigating this, it's been hard to find someone who is a consumer advocate, who is making sure that the consumer, or the patient really, is getting the help they need. So Cheryl has a couple comments here, but this "can anyone help me" is
you get a lot of that.
Yes, I mean, I would say yes.
Yeah, as a very experienced patient over the last 4 years, I mean, I've seen just about almost. I'm surprised I haven't seen you. I may have. I was just a little, out of it. I don't know. But I've probably seen just about every physician in Colorado by this point. But from the patient's perspective, there really isn't anyone. I mean, you can hire someone to help you. You can hire an attorney, but that's still money out of your pocket, and you have to think, is it worth it? The best, something that you can do though, is that you can advocate for yourself, and it is intimidating. I had a dermatologist recently say, oh, well, I can fix that for you, and I just looked at her and I said, for how much? And it was the most awkward pause in the world, but she was able to bring back figures, and we talked about it, and I was able to make a reasonable decision. You know, but you have to ask. You know, as a patient, I mean, a doctor's not going to be offended if you
And that's what I want to ask the doctor here. If I go to your ER, and I'm like, Doc, you're like,
how much is this going to cost me?
You're thinking, are you? I don't. I think most doctors now, we live in an age where it's okay to ask a doctor.
Yeah,
you may not know, but it's okay to ask. Do you think it's okay to ask that question?
Absolutely. I think it's okay to ask any question when you're in the emergency department, and it is such a difficult, stressful, often catastrophic situation. You're not thinking about price. And to be honest, the doctors aren't the experts with pricing right now. I think that will change over time as hopefully the market changes, but I think it's totally an appropriate question.
So can I interject here? Because even though if the doctor doesn't know the cost, they can answer a question like, can I take care of this with my primary care doctor? Can I get this test done at another time? Can I pick this prescription up, you know, somewhere else? Do I have to get it filled at the hospital pharmacy, or is there a 24-hour Walgreens or somewhere else that I might be able to get it filled at a lower cost, correct?
Right. So one of the reasons we started Hippo Health was for that specific issue of you don't know if you need to go to the emergency department or not. Could you go to your primary care? Is there a more affordable way to get the treatment you need? We can easily do that on our service. With the emergency department, it's a tougher situation because the providers and the hospitals are held to a certain standard of care. And so once you're in that environment, it can be more cumbersome. With that said, it's totally fair to ask that question, and you might get a different direction that the care goes if you're asking for a certain kind of care.
Okay, this one's coming from Carol. She says that she had an appointment and was told there was a $50 copay. A month later, she received a $800 bill. Is this legal, and how can they charge me without telling me when I was told? Is this something that needs an overhaul, really, a policy change? I mean...
Yeah, everything could benefit from some change, especially policy change. But yeah, I mean, unfortunately, and this is where there's just a lot of details that have to be asked. For example, what's your insurance? What's your deductible? I mean, all those questions that we've discussed, you know, before are really important. Now, as has already been alluded to, most people, even some people, maybe even us, don't know what their health insurance is or what it actually, how much it costs until you're there, until you're sick, until
we
you're
don't know. We don't know about it until we need it.
That's exactly right.
And so, I mean, I've always said, I could go into our newsroom and ask, what is, because we're all in the same insurance plan here at 9 News. We got one plan. And I could go in and be like, do we have a copay or do we have a deductible? I know we have a deductible. Yeah. I know what the deductible is because I'm the stupid health policy nerd now. But most people don't know about what I mean, do you have a deductible? Do you have a copay? Do you have a mixture of the two? Do you have co-insurance? What's your out-of-pocket max? These are all questions I keep telling people, do not wait until you're showing up at his ER before you answer those questions. Like, if anything, figure it out tonight.
This is one of the dangers that I think has happened recently is that as we've expanded insurance, we've actually gotten a little skimpier on our plans. And so you've got these narrow networks and these high deductible plans where, let's just say you got a new job and they gave you a high deductible plan and you actually don't know what that means. Yeah. Okay, and you're on the hook for maybe $50,000 until your insurance kicks in and you're paying your premiums and you're paying your copays. That adds up. And at the end of the year, you're looking at this and you're saying, wow, I spent more than I made.
Yeah. Well, I actually have a question for the experts, if that's okay.
Yeah.
See, my issue is that I do not have out-of-network coverage at all because I self-insure. And I can check the doctor and make sure the doctor is in network. I can make sure the facility is in network. But what happens occasionally is that I will get this huge bill from someone I didn't even see, I didn't even know that either the doctor or hospital contracted with who is not in network.
So I have an answer to that based on just our reporting. One thing that I've been told is that doctor groups will use the same name. So multiple doctors, and I'm not sure if you've experienced this, but this is what I've been told from different doctors groups, is that the same doctor will use, multiple doctors will work for that same doctor group, and so they just bill it from that name.
Oh, no, I'm talking about like an x-ray. Like if I
They'll
go,
send it out to
they'll send it out
another
to a
doctor
third
group.
party
Oh, sure,
group
yeah, that too.
I've never met. I had no choice
Absolutely.
about. I didn't know, and then I'll get, like I got, for instance, I got a bill for $6,000 for an ECG.
Sure.
I went to an in-network hospital.
That's
and
precisely what happened. I mean, I think you realize that's
that's
precisely what
also
happened with your urine screen.
That is
Is that you went to an in-network doctor, correct?
at an in-network facility.
And that took your urine to an out-of-network facility
Yes.
that tested your urine for all sorts of drugs that I'm sure you're wildly taking on a crazy weekend. I'm sorry, but like, but yeah, it's all joke. It's like so, because it's so ridiculous how much, like what they tested your urine for.
Yeah, we've seen your results already.
We know you're clean, but it's like that's what happens is that people get their labs or their imaging gets sent to places that are out of network, and they didn't even know beforehand. Like what I'm sort of screaming is, how on earth this is legal? But how on earth is this legal?
Which is exactly what we see. I mean, so there's this many different issues that we've come across. So you're getting sent to an out-of-network lab, you're getting a facility fee, you're getting billed for doctors you haven't seen. You aren't sure, especially if you're in the hospital for many days in a row. And I know that there may be some legislation being looked at to address these kinds of things, but what in the short term are patients supposed to do? I mean, one of the comments we got just says, my bill is so confusing.
That's true. It's true. And you know, one thing I wanted to respond to about one of the earlier questions about the surprise bill, you have to be really careful to make sure that the insurance company got it right. There's coding issues all of the time, and you're also able to advance your rights with the insurance company, and then now the Affordable Care Act allows you to appeal the insurance company's decision.
I've noticed that a lot. What I see a lot, the complaints that we get here into the newsroom are a lot of people, like they're left with that $13,000 bill that I know there's no way on earth they're responsible for that. But to me what happens is the insurance company will say, well, there's a problem, maybe there's a coding error, maybe there's something, and they deny the claim. And the hospital still hasn't been paid, and they don't go back to the insurance company a lot of times and say, hey guys, what's going on here? Instead, they just bill the patient directly, and all of a sudden that $13,000 bill ends up in the mail of the patient. That I know they're not supposed to pay that. And so we call the insurance company, and the insurance company's like, whoops, we made a mistake.
Sure.
Right.
But it shouldn't have to take a TV station to get involved in this stuff.
Yeah.
Well, maybe it does. Part of the insurance company's way they make money is by denying payment. And so again, it's a for-profit entity a lot of times that if they deny a claim, then they're saving money. And so they're incentivized to not always play nicely with patients and providers. And we have limited options now in the state with insurance, which is another issue. But I think over time, we just need to continue the conversation around pricing transparency and what's happening in a lot of these situations.
Well, one of the things that I learned just based on that is that when you take this whole pile of different things and you see, I mean, we've seen so many patients go into collections now. I know earlier we talked about wage garnishments being fairly rare, but I went to a courtroom one day where there were probably 70 cases that morning, all scheduled for 9 a.m., that were based on this collection agency. And a few of them...
One collections agency.
It was one collections agency, and that was just one agency that we picked out.
One morning.
70
cases.
Easily.
They probably specialize in.
They do. They absolutely. That's what
Yeah.
they're doing, and it's their. And it was their morning, and they'll be back in 2 weeks, and they'll have more cases.
They do this fairly. I mean, pretty regularly. It's kind of standard practice. And I remember just walking in there, and not very many of the patients show up. So that's a huge problem. We've just got enough people who say, I don't know how to pay this. I don't know what to do. So they don't come, and so the judgment is automatically against them. The few that come, sometimes they can get things worked out, or else they sometimes just agree to another payment plan. Sometimes this is very, very hard to overcome, and that's just one of the things we've seen.
Is there benefit in going directly to the hospital and saying, I can't pay this, but can you work out deals with hospitals and try to sort of say, come to an understanding of like $5,000, no way I can pay that, but can we come up with some sort of agreement here?
Yeah, absolutely. And they have billing coordinators that are able to work with that situation. A lot of hospitals, like I mentioned before, have financial assistance programs where they can help you pay for your bills. Some of them will write it off, or they'll give you a discount, or they'll work with you in some way or another. And the same is actually true for a lot of debt collectors as well.
You know what I found too? I just heard this from a local hospital. I won't name the hospital, but it's owned by a large group. So there's a number of hospitals in the state that fit that category. They said, one of their PR persons told me, deal with the hospital directly, deal with our patient advocates, deal with our financial billing department in Colorado, and stop going to the billing department that's in Virginia, because you're much more likely to have success locally than you will in that national billing office where there's just no sort of patient
I think that's true.
relationship.
Like,
Yeah, you're right.
I think the hospitals are trying to help, and I think if you reach out and find someone within the hospital and you're like, hey, look at this bill, they'll try to help.
Okay, yeah, I just want to say also with the hospital trying to help, I think that when I went into this, I sort of thought that my insurance company was supposed to be negotiating for me. But what we've learned is that insurance companies negotiate for everyone at the beginning of the year. And so talk about that. I mean, you seem to have some familiarity with this.
Again, I'm going to plead not being a total expert with billing.
Of course.
But I feel like a lot of times insurance plans will say, take it or leave it, this is what we're going to pay for this.
Yep.
And if you don't like it, then we're not going to pay you. And then it gets into this game of, well, then we'll charge you more. And then you get this discrepancy between charges and collections, which gets back to why I think historical all claims data would be very helpful for a lot of the parties at the table with healthcare.
I'll say, if any legislator is watching this right now, Civic, and everybody with Civic is watching this right now, please, how do we get, there's got to be a way to get a better access to that information.
Right, and maybe it would make sense to talk a little bit about what Civic is.
Well, the All Fair Claims Database, which I think has been described, is actually a really unique thing for Colorado. It's unique for many states. Not every state has an APCD. And what it does is it basically takes all health insurance claims and it aggregates them into a format that you can actually see price across the state. You can say, okay, well, here and there, this is how much it was. And that level of transparency at a macro level allows you to be a little bit more informed in your decision making. But the most important thing is that it begins to change the dialogue around price. And why are things so expensive here versus there? And it sheds light on an issue that we haven't had light shed on before, which is why APCDs are such a good thing.
Boy, the system doesn't like light in some places.
But as journalists, that is the one thing we can say. We want more information. We always want more information. We are so thankful for you all to join us tonight.
I want to say one thing to wrap this up.
Say the last thing.
Is that one of the things that I've noticed we haven't discussed. I think it's so important because we are in such a political age.
Yes.
We have not talked about Obamacare. We have not talked about Trump
whole
care.
Time.
A lot of this stuff is sort of apolitical. What I found is that whether it be Obamacare or Trump care, we still don't have transparency in the system. And a lot of that, in my mind, is insurance reform, which is important. There is an important aspect to it. But at the end of the day, a lot of this stuff is going to keep on happening, whether it's Obamacare in place or Trump care in place, and you still need to be an advocate for yourself, no matter your political ideology.
Absolutely.
Can we come together at a moment like this and agree on one thing?
We may have more work to do, but that's all the time we have for.
Thank you guys so much for joining us.